Hi, my name is John Carmichael and I'm an endocrinologist at Keck Medical Center of USC, and I'm the co-director of the USC Pituitary Center. Today we're going to be talking about a focus on neuroendocrinology. First, a little bit about myself. I did my endocrinology fellowship at the NYU School of Medicine and worked in the NYU neuroendocrine unit during my fellowship. And after my fellowship was completed, I stayed on and did clinical research with NYU. I conducted clinical research in growth hormone in healthy adults, also conducted clinical trials in growth hormone replacement, and clinical trials in acromegaly treatment. After that, I moved to Los Angeles and started working at Cedars-Sinai, the Pituitary Center there. During that time, I completed a fellowship in translational research, worked with Cedars-Sinai with their clinical scholars program, and this all led to an early career development of expertise in clinical trial design. And I had the benefit of career mentorship from giants in the field such as David Kleinberg and Shlomo Melmed. Once I moved to USC, we adopted a USC Pituitary Center model that benefited the patients in providing multidisciplinary care. This is a multidisciplinary clinic with neuroendocrinology and neurosurgery seeing patients in the same office at the same time. Care is provided by a unified team of schedulers, office staff, nurses, and physicians. We all collaborate to provide the care to the patient with simultaneous care as best we can. Referrals to one specialty are reviewed for appropriateness to offer joint visits with both specialists, and we review records and data prior to the visit so that we can accomplish anything that we need to do for the patients in the time leading up to the visit. Imaging is reviewed prior to the visit at our neuroradiology conference with the Pituitary Center neuroradiologist on a weekly basis. The scheduling is able to provide same-day MRI, ophthalmology, and a joint consultation with endocrinology and neurosurgery, all to provide optimal multidisciplinary care for patients at USC. We have also focused our efforts on research and education in clinical trials with Cushing's disease, acromegaly, growth hormone deficiency, as well as novel methods of diagnosis and treatment. We maintain a comprehensive database for tracking and reporting outcomes, and a program of translational science with genetics and drug development. We also maintain a high-quality lecture series and CME events to train the next generation of endocrinologists and serve as an educational resource for the endocrine community at large. All of this work is based on the idea of a pituitary tumor center of excellence. This pituitary tumor center of excellence is an idea that has been promoted by the Pituitary Society, of which I am a member and a member of the board of directors. We focus our efforts on building a team on the endocrinologist and the neurosurgeon as the principal members of the team, all supported by neuroradiology, neuropathology, radiation oncology, and neuro-ophthalmology. These centers of excellence rely on external endocrine units, the endocrinologists in the community, with referral patterns to this center of excellence to conduct care. And this is all done in an effort to provide excellent care for patients with pituitary disease. This results in the ability to publish our scientific findings and to return these patients, once cared for at USC, to the external endocrine units. As I said, this goal is to provide the best care for patients with pituitary tumors and to organize a multidisciplinary clinical team that's focused on the management of all of the patient's needs. There's a central role for the experienced neurosurgeon and expert neuroendocrinologist, but they work constantly with supporting specialties, and they train fellows in the management of pituitary tumors. It is of utmost importance to provide courses, publications, and lectures so that our findings can be disseminated throughout. I'm going to now talk about the management of pituitary disease and talk about our approach toward pituitary tumors. We're going to discuss the diagnosis and treatment of Cushing's disease, acromegaly care, treatment of prolactinomas, and hypopituitarism management. Of utmost importance is the evaluation of the cellular mass with structural and hormonal assessments. The structural findings rely on MRI of the pituitary and the sella, as well as visual field testing when appropriate. My role capitalizes on the hormonal assessment of patients with pituitary tumors, looking for findings of hormonal excess or hormonal deficiency. We evaluate to determine if the tumor is secreting too much or excess hormones. This is done primarily with history and physical exam to guide the index of suspicion, and this is followed then by hormonal assessments, looking for excess growth hormone in acromegaly, excess cortisol in Cushing's disease from a pituitary tumor, excess prolactin from a prolactinoma, and the rare cases of thyrotropin excess from a thyrotropin secreting pituitary tumor, or functional gonadotroph adenomas, which are extremely rare, causing elevations of testosterone and estrogen. The basic screening labs that are employed to evaluate patients with pituitary disease are prolactin, IGF-1, looking for growth hormone excess, assessment of the gonadal axis with luteinizing hormone and follicle stimulating hormone, as well as measurement of total testosterone in men. For women, menstrual history is of utmost importance and in fact is probably superior to hormonal testing in the premenopausal women. Thyroid assessment relies on TSH and concomitant measure of free T4, and cortisol excess is assessed clinically, followed by screening tests if indicated, and we'll go into that further as we talk about Cushing's disease. Adrenal insufficiency likewise is assessed clinically, and the index of suspicion is raised by the presence of other hormonal deficiencies. When needed, we check a morning cortisol and rely on stimulation testing for establishment of the adrenal reserve if necessary. Cushing's disease is, I think, by far one of our most complicated diseases to treat. It is a challenging diagnosis to make, not only because the complexity of the testing involved, but because the features of Cushing's disease are very similar to those found in the general population. It is of utmost importance to exclude exogenous glucocorticoid exposure and to then perform testing of urine excretion of cortisol, of suppression of cortisol from tumoral or non-tumoral sources, assessment of late-night salivary cortisol to obtain an estimate of diurnal variation of cortisol. And once these things are complete, and once we have established that the patients have Cushing's syndrome and elevation of cortisol, it is at that time that we start looking for the source of the abnormal cortisol secretion. Cushing's syndrome symptoms are sometimes very specific, but often are poor discriminators of disease. We see patients very commonly who may have Cushing's disease because of the symptoms that they report, such as obesity and hirsutism, changes in fat location, including relocation of the dorsocervical fat pads, and facial fullness that is a striking feature of Cushing's syndrome. But these, unfortunately, do not discriminate the disease from those patients who do not have elevations of cortisol from a tumoral source. We have to rely on specific signs like facial plethora, proximal muscle weakness, wide purple stria, and easy bruising that tell us more likely that the patient has Cushing's syndrome as opposed to findings that are found in the general population. One of the most complex parts of the treatment of patients with Cushing's syndrome is the use of novel medications. For many, many years, there were few medications that were available to treat patients who were surgical failures for Cushing's disease treatment. And recently we have seen approval of several new medications. Unfortunately, these medications are complex in their management. There are multiple drug interactions. There are challenging side effect profiles. The efficacy is sometimes limited, and it's uncertain what role these medications will play in the long-term management of patients with Cushing's syndrome. And so we are left with a highly individualized approach toward each patient. And this is reliant on multimodal care with incorporation of surgery, sometimes second surgeries, and radiation in many cases. There's also a need for lifelong monitoring, as recurrence can happen in decades to come after a successful treatment initially. Acromegaly, or growth hormone or IGF-1 excess, is a complicated and difficult disease to treat. It can be very disfiguring to patients who are suffering from long-term exposure to high levels of growth hormone, and unfortunately it takes several years for them to come to medical attention because of the slow and insidious onset of growth hormone excess. The goals of therapy, regardless of the mode of treatment, are to control that growth hormone secretion, to normalize age and gender matched IGF-1 levels, to ablate or reduce the tumor mass and prevent its recurrence, and to reduce symptoms associated with the mass effects of the tumor. All the while, we are trying to alleviate significant comorbid features of the disease and normalize these patients' survival time. Management of acromegaly relies initially on transsphenoidal surgery for most patients. From there, assessment of disease activity is done, and after the surgery is complete, if the patient is in remission, we then employ a surveillance of annual monitoring of growth hormone and IGF-1 levels and imaging findings to make sure that the patient is free of disease. If the disease is persistent, we then have several medications that are available for us for the treatment of acromegaly, with medical management aimed at suppression of growth hormone secretion or blockade of growth hormone once it's in the periphery. Some of these medications have the advantage of tumor suppression and control of tumor size as well. If these things fail, we often need to rely on other modes of therapy or combinations of therapy, and in very few cases, we need to rely on radiation treatment. As I said, surgery is the initial treatment of choice. And in this case, surgeon experience and degree of invasiveness are key predictors of outcome. Studies have shown that a single surgeon model, rather than multiple surgeons treating patients with acromegaly, have benefited patients with improved outcomes and higher success rates of surgery. If those patients are still not cured by surgery, there are multiple medical choices, and there are novel and emerging compounds. We continue to participate in ongoing clinical trials in oral compounds, and there are multiple opportunities for hormonal and tumor control with combination medical therapy. There are also investigations that we are undertaking into targeted therapies to control patients' disease and to alleviate some of the symptoms of growth hormone excess. Prolactinomas are among the most common secretory pituitary tumors that we see. Patients with symptomatic prolactinomas are commonly treated with medical therapy as a first-line therapy. Once these patients are controlled with their disease, we monitor their prolactin level, monitor their imaging, and visual fields if necessary. Prolactinomas, however, can sometimes be very resistant to treatment, and in those cases, or in the cases of intolerance, we need to rely on other modes of therapy. We have employed a clinical protocol of increasing the dose of cabergoline and bromocriptine to high doses to control patients with medical therapy alone. And we've had a great success rate in doing this. When we titrate the dosing to maximum dose, we get good efficacy with almost all patients controlled with their disease. In some cases, though, we have to rely on surgical excision for treatment of patients with resistant or intolerance to medications. Here's an example of a large pituitary tumor with a very high prolactin level. And even in cases where the tumors are large and the prolactin levels are very high, routine doses of cabergoline therapy result in normalization of prolactin. In this case, you see in the first 3 months a dramatic lowering of prolactin in response to medical therapy. And over 1 year's time, we see a reduction in tumor mass, all due to medical therapy alone. This patient continues to see me, and his MRI has normalized as well as his prolactin, all with the treatment with medical therapy alone. Hypopituitarism is another aspect of pituitary care that relies on complex testing and an expertise in management. Many cases rely on dynamic testing, timed tests with agents that are employed to cause secretion of growth hormone or cortisol so that we can address patients' growth hormone or cortisol deficiencies. There's diligent attention to medication interactions, as all of these medications may need to be employed in someone with pituitary failure. These patients also require long-term follow-up and dosing adjustment with age. We have been part of clinical trials looking at novel medications, both for hormonal replacement formulations, as well as new testing agents employed to diagnose patients with pituitary failure. And we continue to participate in ongoing clinical trials in this area. I would like to acknowledge the other members of the USC Pituitary Center team, without which our center would not be successful as it is. I would like to thank Gabriel Zada, my co-director, as well as our nurse practitioner, Emily Rorden, and our nurse, Monica Chu, who form the core of our Pituitary Center team. We also rely on colleagues in neuro-ophthalmology, neuroradiology, radiation oncology, neuro-oncology, otolaryngology, and I need to acknowledge our predecessors, Dr. Martin Weiss and Dr. Peter Singer, who formed the foundation of the USC Pituitary Center with decades of work treating patients with pituitary disease. I'd like to thank you for your attention.